going to listen to your lungs and heart and listen to your abdomen. Is that a good time to do that?
Sure, yeah.
Okay, great. So I'm going to start with just listening to your chest first. And then I'm going to ask you to probably lie down at some point. And I'm going to kind of, you tell me what's okay and what's not okay. Like if you don't want me to expose your abdomen, then let me know. I want to be respectful, but you know, that health assessment is sensitive, and so I'm gonna, and you guys give each other feedback. I don't want anybody to feel uncomfortable or violated in any way, but I also want to make sure that you have an opportunity to practice, okay? So that's the fine line we're kind of walking here. Okay, so I am observing Kit right now, and he is not in any respiratory distress. And I know that because I'm observing the horizon fall of his chest. He's not using any accessory muscles. He's not using his sternocleidomastoid muscle. He doesn't look anxious. He doesn't look in distress. And the patients who look in distress, sometimes you will see that they're really straining their facial muscles and they're holding onto the rails. They're leaning forward, trying to get a breath, and so I'm not getting any of that. I would like for you to pull your mask down for just a second, please. And so I am looking also at nares flaring. Remember how people, usually kids, will have the nares will flare as they're breathing more, trying to get more air in. And I'm also assessing for, I don't know why I put my mask down, assessing for signs of cyanosis as well, right? And so I don't see any of that as well. It's hard to separate cardiac assessment from everything else because really, you know, I want to make sure that he's not anemic, which would be part of my cardiovascular assessment. And so I'm looking at his eyes, and I'm going to ask you to pull your eyelids down a little bit. And so I'm looking to see a little bit more. And I'm just looking to see if they're pink, or really, really pale. And also looking at the mucosa membranes as well, and making sure that they're kind of well hydrated, so to speak. All right. And then I'm going to just start listening to the lung sounds. And we talked about lung sounds sort of starting with a tracheal sound. So I turned it to the bell yesterday. I'm going to start here and just breathe normally. And take a slightly deep breath. And I'm going to listen to the full inspiratory, expiratory cycle. So I need to listen on skin because otherwise there's going to be too much friction. So I'll slide my stethoscope in one more place right here. Lung sounds are clear throughout anterior chest. Does that make sense? So anterior, clear. Okay. The next thing I'm going to do is listen for bruit, and that's what we talked about yesterday a little bit. So I can check his pulses. So temporal. Okay. And then carotid. One at a time, so I'm sliding my fingers and just feeling for his carotid pulse. Once I find it, I'm going to put my ears in, turn it to the bell, and ask you to hold your breath. Okay, and breathe again. I'm going to do the same on the other side. So find the carotid pulse, put my bell on, and hold your breath. brushing sound. So no bruit, which is what I want to hear. I'm going to check skin turgor, and you can see that his skin goes right back, so that's good. On somebody who is younger, you are more than welcome to check the skin turgor on their skin. I probably wouldn't do it on the older person. Like, you can see how even there's a little bit, right? It's not because I am dehydrated, it's because I have some wrinkles on my hands, right? So older people, probably not a good place to check. Okay. So we checked for skin turgor or bruit. We checked the temporal pulses. We checked carotid pulses. We checked the lung sounds. Here you have a choice. You can ask your patient to lie down, because sometimes listening for the heart sounds is easier when the patient is lying down. And that way it will make it easier for you to do abdominal assessment as well, just because it will flow better. So you can choose to do that and sit your patient up after that and finish the lung assessment in the back if you like. This flow of things is entirely up to you guys. I am just gonna go and listen to his lungs in the back, just because I don't want to forget right now, okay? So I will put my stethoscope back, and then kid, give yourself a hug. And so I'm going to find that middle lobes on the right side and the left side, and especially the right side of an importance to me, because if somebody were to aspirate, that's where it would end up. But I will check both sides. And so deep breath. Well, actually, you don't have to. And I'm just, because I'm doing it over his shirt, I'm just going to show you where the placement for that would be. Remember where the diaphragm is, so you want to stay above the diaphragm. And so same as on this side. 1, 2, 3, and 4. And then I will go to the back. Can I have you just turn your back a little bit? And so we'll start. Remember how we palpate the spine, right? And that helps us with our musculoskeletal assessment, but it also helps us figure out where to put our stethoscopes. So his scapula is here and here, and then his spine is right here. And I want to place my stethoscope in the space between the two. So I'm going to start here, and then move to the other side, and go down, and one more time. And it's always top to bottom, side to side. And the reason I'm doing that is because I'm really interested in the comparison of the sides. It is possible that he has fine crackles on one side or rails on the other side. If he had some kind of surgery like lobectomy or something like that, the lung sounds on one side would be different from the other side. If he had pneumonia, usually, you know how you will hear left side pneumonia, so the left lung will be more involved than the right one. So you want to listen to the differences. Usually if like somebody has a pleural effusion or empyema, usually on one side, and so really important that side-to-side comparison.
And it's like take a breath in and blow it out.
Yeah, so let's do it. Take a couple of deep breaths for me. And out. So again, you can tell your patient, take a deep breath every time I move my stethoscope.
Okay.
Or you can time it. And watch your patient. You guys have noticed that it's really kind of a lot if you're doing front and sides and back, right? So that's why I like to break it down with a cardiac assessment. I'll do the lungs in the front, then I'll listen to the heart, and then I'll finish the back. Because my patients are not you usually, and it's a little bit harder for them to do all that breathing, right? So that's normally how I would try to break it down. So go ahead and lie down if you don't mind. I'm gonna raise the back one so you can come. And I can stay on this side if you think it's going to help you guys better. And so now, is that okay for me to lift your shirt? Okay. So you have something underneath. Okay, good. So go ahead, maybe. Are you okay, T? Trying to be sensitive, guys, but I just don't know how to do it without, how to get to the heart without getting to the heart. All right, thank you. All right, so this is the part where a lot of students struggle, and it does take a little bit of time. What you want to learn how to do is palpate, right? So this is his clavicle, and I'm just palpating his clavicle. Does that feel odd? That all of us are watching?
No, okay.
Sorry.
I feel like I'm in surgery.
Bring out the scalpel.
She's a surgeon right here.
So this is his clavicle, and this is the sternum, right? And we talked about these are our important landmarks. So we're gonna do, and the reason I'm kind of taking my time sometimes, like you're like, what is she doing? Everybody's anatomy is a little bit different. Look at all of us. We're not the same. Somebody's bones are really big, somebody's bones are really small, somebody is very petite, and somebody has broader structure. Think about somebody from like Samoa or Japan, right? Like people are different, and so to understand where things are, you kind of need to palpate. And sometimes you'll be surprised. You're like, oh, I thought they were so petite, but that they have these really large bones, right? And so what you're doing is just kind of figuring out, okay, this is his clavicle, this is his sternum. Okay, now I have a patient, who's maybe has a little bit more weight, or somebody who's really petite, or somebody who has very sensitive, because they have underlying conditions or whatever else. So I'm just trying to kind of figure out, and I will tell my patient, if I'm pressing too hard, let me know. I do need to apply a little bit of pressure because I am trying to get through the layers to that, to the bones. And so one thing that I would suggest, don't poke, because when you poke, it's really hard to know when the structure is shifting under you, when you're going from a rib to an intercostal space. Roll your fingers. It's going to be more comfortable for your patient, but it also will give you a chance to know when something is changing underneath. So you see how you can see my fingers go up and down, and so when they're up, I'm over a rib. When I'm down, I'm in the intercostal space. Does that make sense to you guys? Okay. So we said clavicle, and you can look at the mannequin again. And the first rib is going to tuck in and go this way. So second rib, second intercostal space. Okay, right here. So this will be where I listen. And this will be his aortic valve, right? And so I'm just going to put my stethoscope back in. Make sure that I switch to diaphragm, which I did. So I'm gonna listen. And it takes a while to kind of get the sound because I'm listening to, remember when we listened to the lungs, we were also in this area. So I'm hearing his breathing as well. And I really need to just kind of mentally isolate that sound. And I'm hearing lub-dub, which is what I want. So I'm going to just kind of make sure I am in the right spot. And so that's my pulmonic valve. And then I'm going to go from there down to Erb's point.
and I hear again, lub-dub, lub-dub. I don't hear any whooshing, any murmurs. I don't hear any stenosis. I don't hear any S3 or S4s. And so from there, I will roll my fingers down one more time, and that will be my tricuspid valve. Notice two things that I am doing. One, I'm pressing a little bit harder probably than maybe you would think that I see how it leaves. One, it makes the sound. So I'm creating that suction, that seal between my stethoscope and his skin to help me hear better. And then the other thing, you can see me, I'm palpating, and then I'm putting my stethoscope right under that spot. I'm not moving my finger too far because I can't see his intercostal spaces. I can only feel it. So if I move my fingers, then I need to repalpate again. And so that's kind of how I want you guys to do that too. And again, like, you know, I've been a nurse for a little bit, and yet I'm palpating every single patient. It's not like you can look at somebody and say, that's where her second intercostal space is, right? So just give yourself some time and space and know that your partner is really just trying to palpate where things are. And if they're pressing too hard, let them know, because you guys don't know that yet. You're still learning all this. So that's our fourth, and then I need to get to the fifth intercostal space. So that's right here. And so this and the mid-clavicular line, right? Remember that? So clavicle is here, right here. Mid-clavicular line is about here. So I'm drawing a line here, and I'm drawing a line here, and this is where I would end up. Okay, and so then you would put your stethoscope here, and when you're practicing with each other, you know, I don't know if you guys have like sports bras or tank tops, but feel free to pull the curtains and really kind of let your partner.
So how do you find that with breast tissue?
All that.
You just
Yeah, exactly.
and then go up in here?
Absolutely.
Okay.
So, you know, like, you guys know what we're doing, and so you can say to your patient, I need to, or to yourself, I need to listen to your apical pulse. It is right underneath your breast. Do you mind holding it up for me? And so in clinicals, so you ask your patient, and then you can wrap their gown or clothing or whatever they are wearing, and you just kind of lift it up for them, or put their hand on there and have lift that up a little bit, and then you slide your stethoscope up. Couple of things will help, like you can ask, you know, the strap will help. People also in the long-term care facility won't always wear bras, which is actually more helpful to us, because you know, you don't have breast tissue concentrated in one spot. So if it's a little bit more spread out and they're lying down, you can also shift that a little bit. You are not the only person who is checking apical pulse, and they're a lot more comfortable with that than you think you would be. Couple of tricks: if you have a patient who is heavy or has a lot of breast tissue, you can always ask your patient to either roll on their left side, because your heart is not cemented in your chest. It is supported by the lungs and the structure and pericardium and everything else. But when you shift position, the heart will shift with you as well. And so you can ask your patient to roll onto their left side, and then you will be able to palpate it better and sneak your stethoscope. You can also ask your patient to lean forward. That will also bring the heart closer. And so you just, yeah, and still lift the breast tissue up. It's just what it is, right? And so apical pulse, once you get there, so Pushing too hard. Too hard?
You're okay.
Okay. Okay, and so I would come over here and I would just put my stethoscope like so and press it down a little bit and shift the breast tissue up a little bit on your female patients. And then this is the place, you know, make sure you guys are comfortable, like standing, because you're listening for a whole minute. You're counting apical pulse for a full minute. And we talked about the importance of that yesterday. You know, your patients who are on digoxin or atenolol, metoprolol, that kind of control the rate of the heart. If you just check the radial, you may not be getting the clear picture of what the pulse is, and then you're giving medication that potentially can really hurt them, right? Because digoxin increases the contractility of the heart, but also slows that down, slows the heart down. And so you need to know what the accurate pulse is before you give that medication. Metoprolol is also controls the rate, and so if you check blood, you check it here, you may be missing those little contractures that are not making it to the radius. Does that make sense? And so, when you're listening to the heart, you're paying attention. S1, S2, right? The rate and the rhythm, and then paying attention to any murmurs. Know that you will hear lung sounds, so spend a little bit of time just listening and be like, okay, that's the breathing, oh, that's the vowel tones, because you're going to hear it all, right? Okay, so any questions about that piece?
Yes.
Yes.
What if my patient has a pacemaker? Do I do the same assessment?
Yeah, it's a great question. Your patients may have pacemakers, you still do the same assessment. Because if they had, if it malfunctioned in any way, if it changed their rate, right? But also they could have murmurs. The reason you're listening to those spots is you're assessing the health of the valves, and that is not necessarily the rate. Does that make sense? So yeah, and it's a good practice. Okay, so that's that. If I were to do the abdominal assessment next, is that okay if I lift your shirt a little bit? And you would tell me if it's not right. Okay.
Is it okay if I record?
And so all I am doing right now is just observing. The reason I'm observing first is because anytime I mess with the abdomen, it will change the sounds, and we'll talk about that in a second as well. So I'm looking any hernias, any bulging, any ascites. If you saw patients who have liver failure, the ascites, right? Any scars, any bruising, any lipohypertrophy. Lipohypertrophy is something diabetics get when they inject in the same spot again and again, and it kind of creates the kind of a bulge. So I'm just observing. Is it flat? You guys, we talked about it in the PowerPoints and the lecture recording. Is it flat? Is it distended? Any of those things. So that's what I'm looking for. Next thing is always going to be auscultation. And I'm going to place my stethoscope in 4 quadrants. And so, you know, okay, so 2 things. The current literature suggests that if you put your stethoscope in the right lower quadrant and you hear vowel tones, you can say that the vowel tones are good throughout. And that's fine. If you don't, or if you need to do a more specific assessment and you need to listen in all 4 quadrants, then you divide the abdomen using the umbilicus as a landmark. So this way and this way. You could start in this or right upper quadrant, whatever works for you, and then you lightly place that, and you wait until you hear a gurgle. Okay? Now, if I start pushing, what am I doing? I am moving his GI tract, right? Because there is no solid structure. So all these small intestines are right under there. And if I start pushing on it first, then they are moving. And when they are moving, they're making a sound, a bowel sound that gurgles. So if I go ahead and just palpate his abdomen all over the place and then put my stethoscope on, I artificially created those sounds. So I can't really say that he has bowel tones, right? We generate about 1 liter of saliva a day. If he had any obstruction somewhere, things would start building up and he would be really uncomfortable and he wouldn't be passing gas. His abdomen would be distended and he would not have any bowel tones. Actually, if somebody gets an obstruction, their bowel tones get hyperactive because your body's trying to get through and then they kind of stop altogether. So just know that you always need to listen and describe them accurately. Normal bowel tones are what? We don't say normal, right? We say active or hyperactive or hypoactive. So that's how you describe them. How do you know that they're hyperactive or borgerismus? So if it's 1 every how long?
10 seconds.
I think we said if you get them within like 1 minute or 1 to 3 minutes, you're okay. That can be active. If you do not hear bowel tones, you will listen for the full 5 minutes before you declare them absent. So that's a long time. And again, somebody can have an obstruction still having bowel tones because your body is going to try to push things through. But if your patient is nauseated, distended, not passing gas, it's more likely that there is some kind of partial obstruction at least. Yeah.
Is that per section that we would listen for that time? Okay, so
I
like,
know,
okay.
I know. That's the old guideline. So the new guideline is that you only listen in right lower quadrant. If you have bowel tones, then you can say patient has bowel tones. It's only when they are completely absent that you have to do this. And then I will palpate. And so when I palpate, put your dominant hand on top of your non-dominant hand. That's one technique. And then gently press down and rotate your fingers a little bit. And then move and do the same. So ask your patient to kind of relax a little bit. And then if it feels uncomfortable or tender, let me know. And so I am systematically rolling my fingers all over his stomach. Notice also that I am pressing down a little bit and then moving my fingers. That way I can feel the structure underneath. Like I know where the stomach is and where the pancreas is and where the liver is and where the colon is. And so as I am rotating, I'm kind of thinking like, okay, I'm over his colon now, or like I'm over his duodenum now, or whatever else. And so it gives me a better understanding if somebody says, oh, that hurts, that tender. I can kind of understand what structures are underneath. Yeah.
So do we, when we palpate, are we starting with the right lower, or just is there just kind of make your way around?
When you're palpating, make your way around
Okay.
the abdomen. Yeah. So that's one technique. Sometimes people will just do one hand, but if you're using your dominant hand, you accidentally could be pressing a little too hard. So just maybe use your non-dominant hand. And use, whatever you choose, do systematic assessment, go all around. You should be wearing gloves too. Percussion is, I don't know if ATI talked about percussion, but I just think it's one of the coolest things, so I'm going to show you, but you don't have to like do it. So listen how it sounds here. Can you hear?
Can you do that one more time? Because my brain is working.
Your brain is working?
This is reminding me something because when my daughter was a little baby, my mom was doing something like that, and she's like, "Oh, you just feel she has gas or something like that." And I'm like,
So-
"What?"
So now listen to this. I'm gonna go go over his bone. You see how the sound changes?
Yeah.
So before we had x-rays and before we had like, oh, this patient has pneumonia, we know what it should sound like over a hollow structure, over a GI tract, for example, or over a bone, or over a fluid, right? So if I go and listen to his lungs and it sounds like a solid, then I know there is something going on, right? And so this was a really fun tool. And some physicians still will use it. I have not seen nurses do it. Okay. You see how it changes?
Yeah.
Yeah, exactly. So if you're like you have a patient who's really constipated, and you're palpating, you're like tapping, it's gonna sound like a mess, like a solid mess underneath, right? I know, it's
That's
so fun.
cool.
I know, I'm sorry. I get excited about these things, but they're like not necessarily, they're kind of things that, sort of physicians lament us as well as nurses. The physical assessment skills are not as what they used to be, because if I found somebody that I was worried about having a mass, I'm not going to palpate. I mean, I might percuss, but I will send them to x-ray anyway, right?
Mhm.
To see. All right, so we checked his heart, we checked his abdomen. I am looking at his fingers, and I'm looking for clubbing. And I'm also looking for capillary refill. And to check capillary refill, you can just press on his finger and his nail, and count how long it takes for the color to return. So within 2 seconds, would you agree with that? Like, you want like one more likely? If you have a patient who has nail polish on, you can use the other side. You can use the pad of the fingers. You can also have them like try to take one finger off. But again, so that is how it works. Then we're going to skip the femoral pulses and popliteal pulses, and then we're just going to go down to dorsalis pedis and posterior tibialis. Is that okay if I take your socks off? All right. So dorsalis pedis is on top of the foot, dorsalis pedis. Where should it be? Well, I think your ATI says follow these two toes, and where they meet is where the pulse is. Sometimes yes, sometimes no. I find it is usually on top of the foot, and I just say, okay, that should be here, right? And so I'll put my fingers down. Again, I never use just the pads of my fingers, because I am only covering this much of his skin. So I have to go like this for 10 minutes, or I can just place the whole pads, and that way I have a better chance of picking it up sooner, right? So you had some surgeries on your feet.
They put metal in it.
And sometimes when they do surgeries, it's harder to find the pulses, but his is strong, and his is right here, like right under this finger. So I would check, so the dorsalis pedis, and then posterior tibialis. And so he has a really strong pulse here. And so look where my fingers are. You see the ankle bone, so I'm going posterior behind the tibia. Where is the tibia? That's the bone here. So I'm going behind it.
To the malleolus?
Kind of.
Okay.
And his is like really strong. Usually I just try to wrap my hand around the ankle. And if I don't find it there, then I'll start moving around a little bit. posterior tibial dorsalis pedis. If he did not have a pulse, then I would say let's use a Doppler and see if we can find his pulse. You're gonna be so excited that you volunteered for this. Doesn't it feel disgusting? He's like, what did I sign up? All right. I may need to get a different one. Hang on. Am I gonna work? Oh yeah, I think we're gonna work.
No.
One. Sit up.
I know, right? Well, clearly I can't find it anymore.
Oh,
there it
there.
Well, let's go to the other one because the other one is fun. Okay, I lied.
That's cool.
Oh my gosh.
Congratulations. Okay, so that's what you would do. And I suggest you guys grab a couple of paper towels for me, Tori, please. So that's that. So we check the pedal pulses. We'd use the Doppler if we need to, and then we also use check capillary fill. As you are doing this, you're checking the skin color, and also, thank you so much. You're also looking for, I know it's kind of dopey, but you're looking for the hair distribution, because if there was an area that didn't have circulation to it, you guys would be able to see that. Hello!
I'm like, oh, that's a real person.
Let's poke him and see if he. Okay, so you're looking for hair distribution for warmth, and you're checking the warmth with what part of your hand? Yes, exactly. Exactly. Back of your hand. Okay. Hey, that hair's, you're looking so cute.
Don't stop.
We talk every morning just to see what you're wearing. And then remember that you always do it on both sides. So one foot and then the other. Because again, he had surgery on one foot, not the other. He had, let's say they did a bypass years ago and they took a vein out of his leg, right? So you may see a little bit of edema. If he is a female and they had mastectomy, you may see edema on one side, not on the legs, but upper arms, right? So you always go side to side. You check for temperature, and then you look for discoloration. And if he's in, somebody who has arterial vascular disease, then his extremities would be pale because the blood is not flowing there. If he had venous insufficiency, like the blood doesn't flow back up to the heart, then it kind of seeps into the surrounding tissue, discoloring it into like looking more of a brownish purplish color, and then people develop like patches and then ulcers. It is not attractive looking, comfortable for the patient as well. All right, any questions? Yes.
Sorry, this might be dumb, but we just did the cardiac and abdominal assessment. So when we're doing the listening for the heart, we're listening to the front and the back. So we would do the respiratory, first, or
I don't
and then go from there. It just
So
seems very.
truly, Kat, I never do an assessment twice in the same way, and I don't want you to get like this is it. You need to listen to the lungs. Oh, my patient is standing up. I'm going to catch their back first, right? You want to develop your own flow, because if you're trying to adopt somebody else's, that's going to mess you up.
Yeah, for sure. But I just it might be dumb. It's like, because, we're listening to like my mindset, because it's kind of a blur. So I'm like, we listen to the front and we listen to the back, and then wait, that was just cardiac. So like that
We
seems so
did
similar.
lungs and heart.
Lungs and heart. Okay, thank you.
We did lungs
So
and heart.
okay, never mind.
Right?
I'm
Because
good.
we listen to
The sides
sides
inside.
as
Okay.
well, and we don't listen to the heart on in the back.
That's what I was thinking. I was like,
Yeah.
that's why I asked. We just did cardiac and then abdomen because it looks like
the
lungs.
pulmonary.
Okay.
Pulmonary.
Oh,
We did
okay, I'm
pulmonary
good.
as well. And you can adapt this. Remember how I listened to the lungs, and then I pretty much stayed in the same area to listen to the heart. So if you can hold it together in your head and like separate, you can say, okay, this is palpating second intercostal space, listening to the heart. Hey, I can hear lung sounds. I'm also listening to the lungs in that spot. Totally fine.
Okay.
Absolutely fine.
All right.
So when we do our assessment, do you want us to say what we're doing out loud so that you know, that's what
course.
we're
Yeah.
like?
Of course. And I think it will help you guys if you're talking it through, because you're not going to be as nervous and you're not going to forget it. You're going to be like, I'm listening to lungs, and then you'll be thinking, okay, I usually listen to the heart after that, and things like that.
Yeah, so if a patient, if you're sitting here like for 20, 30 minutes listening to their, bodily sounds, how do you kind of like make them feel comfortable and not like?
So you're never going to be, well, okay, maybe the first 2 weeks, it's